What we'll do now is talk about sinonasal tumors, what you need to know. And the most common tumor for tumors that involve the sinonasal region is squamous cell carcinoma. And this arises for about 3 to 4% of head and neck neoplasms. The incidence is approximately about 1,000 per year. I should say 10,000 per year. The incidence in males is greater than females, and typically it's involving the maxillary sinus. And the thing is that we really don't need to give a differential diagnosis for this. Everyone can look at it across the room, and the patient knows they have squamous cell carcinoma. But what I want to do is just briefly talk about some of the things to include in your report when you're looking at patients with squamous cell carcinoma. So first thing that we want to look at is whether or not there's extension into the orbit. Because what we're trying to really determine is whether or not a patient can undergo this procedure or this procedure. This procedure is a removal of the globe, and this procedure is preservation of the globe. And so the first thing that we have to do is whether or not there's extension into the orbit. So in this particular case, we have a sinonasal carcinoma, and we can see the lateral aspect of this is maintained by the lamina propria. So in this particular case, the globe can be spared. But in this particular case, we can see there's some early extension in the medial aspect of the orbit. And if there is, this information needs to be conveyed to the surgeon because this is going to be an intraoperative decision whether or not the globe can be spared. And in this particular case, we can see the tumor has grown all the way into the inferior aspect of the orbit and has completely engulfed the inferior rectus muscle. So in this particular case, there's no way to save the globe, but those are all elements of intraorbital extension, and they all have its implications regarding the surgical approach. So another thing that we have to look for is intracranial involvement. So in this particular case, there's erosion of the inner table of the frontal bone. This is intracranial involvement. However, the implications of this, which can be resected en bloc, is different than if we say there's intracranial involvement here. In this particular case, we can see there's enhancement of the meninges, and if there is enhancement of the meninges, this information needs to be referred on to the surgeon, because in this case, this could either be inflammation or it could be recurrent tumor. So this needs to be biopsied by the surgeon to see whether this is tumor or whether it's inflammation. And here's another example of intracranial involvement. In this case, we can see the tumor is directly extending into the frontal lobe, and this has a substantial amount of surrounding edema. And in most instances, if we say this to our referring physician, then this means there's brain invasion, and these patients will not undergo resection. So all of these are important information that need to be conveyed to the referring physician. The other thing that we always have to talk for is perineural spread. We heard a little bit about this earlier. If there are tumors that involve the posterior wall of the maxillary sinus, we need to look for involvement here of the second division of the fifth cranial nerve compared to the left. And if there is, it's possible that this could extend all the way back into the cavernous sinus. So those are three things that we always need to mention in our reports. Is there intracranial involvement? Is the orbit involved? And is there perineural spread? So number one, the most common tumor that we'll talk about is squamous cell carcinoma. Now, what do we think this tumor is? This is the second most common tumor to involve the maxillary sinus. And what do we think this is? Anybody? What's that? So this is lymphoma. So if we're building our differential diagnosis, the second most likely tumor to involve the maxillary sinus and the nasal cavity is lymphoma. The majority of these are T-cell lesions. They're oftentimes associated with Epstein-Barr virus. They're a little bit more common in Asians, but again, from an imaging standpoint, they are completely non-specific, and there's nothing we can do. But what we can do is always remember this in our reports. So again, this just emphasizes the non-specific findings. This is a T2 weighted image. These are both lymphomas. In this case, it's intermediate signal. In this case, it's low signal. This case, it's both intermediate signal, and here we see differential enhancement. This one enhances a fair amount, this one not so much. So again, the imaging findings in lymphoma are non-specific. So, number two is lymphoma, and really I can't tell you much. There's really nothing specific about it, but how about this lesion? Now in this particular case, we do have a tumor that's involving the right maxillary sinus, extending into the pterygopalatine fossa. And anybody know what this is here? This is what? What's that? It's a V2, but what about the V2 on the right compared to the left? What do we think this is here? This is perineural spread of tumor. So this is tumor growing along V2. So if we have tumor spreading along V2, any ideas of what type of tumor this could be? Are there any head and neck tumors that have a propensity to grow along the nerves besides squamous cell carcinoma? What's that? Exactly, minor salivary gland tumors. So when we're building our differential diagnosis, squamous cell number 1, lymphoma has non-specific findings, but if we do see any type of tumor that has perineural spread, we always have to consider the diagnosis of some type of minor salivary gland tumor. And this can be mucoepidermoid carcinomas, or they can potentially be adenoid cystic carcinoma as well too. And again, when you look at the imaging findings on its own, again, they're non-specific. It's the presence of perineural spread. So here's a tumor that typically involves the sinonasal region, and the reason why I show this is that it has a bit of a characteristic appearance. If you see these findings, this may suggest what this tumor is. And if you look at it, it almost has a cauliflower or a cerebriform shape to it, and there's a little bit of dystrophic calcification that can be seen in it as well too. So can anybody think of a benign tumor involving the sinonasal area that typically has a cerebriform or a cauliflower shape to it that's benign? What's that? I heard it. Not angiofibroma, but inverted papilloma. Okay, have you heard of inverted papilloma? Right, so this is inverted papilloma. So inverted papillomas are a little bit more common in males than females that have an endophytic growth pattern, and this is a pathologic specimen of an inverted papilloma. And when you look at this, you can see all these fronds. It almost looks like cauliflower. And when we go back and look at this study, you can see why this has a morphologic pattern to it. So inverted papillomas are benign lesions, but however, about 10 to 15% may have some type of underlying squamous cell carcinoma. They also tend to be unilateral. They involve the lateral aspect of the turbinate. And again, another example of the typical finding of inverted papilloma. Again, I want to point out that cauliflower, or if you will, cerebriform appearance to it. So far, what have we talked about? We talked about squamous cell carcinoma, which is the most common. We talked about lymphoma, which has nonspecific findings. If we see perineural spread, we think of minor salivary gland tumors. If we see a tumor that has a frond-like enhancement or has intratumoral calcification, then we want to think of inverted papilloma. Now, what about this? This is the tumor that's involving the right maxillary sinus. And when you're getting your history, what if I told you this was a child? If this was a child and you see something like this, then what's the first thing that you think about? Yeah, everyone's saying, how many people are saying juvenile angiofibroma? Okay, what else could it be? Fibrous dysplasia in a kid? Right, rhabdomyosarcoma. So the key thing here is that if you see an aggressive lesion in a child, we have to think of rhabdomyosarcoma number 1. Keep fibrous dysplasia in your mind because we'll see that later. But rhabdomyosarcoma is the most common soft tissue malignancy in the head and neck in a child. So the imaging findings, as you can see here, are pretty nonspecific. This looks just like squamous cell carcinoma. 40% occur in the head and neck, typically in children less than 5 years old, and the locations are identified here. This is a contrast-enhanced T1 weighted images. We can see with fat suppression, we can see the enhancement. The diffusion weighted imaging demonstrates that it's very, very low signal, and here we can see the aggressive bone destruction. But again, if we look at these imaging findings alone, they could be anything. But how can we suggest that the tumor is rhabdomyosarcoma is that if we see a soft tissue malignancy in a child, all right? So we're building our differential diagnosis, right? Now what about this? Now what if I told you that this was an adolescent male? Nasopharyngeal angiophybroma. Now everyone gets that one, right? So this is a juvenile angiofibroma, right? So we have the typical appearance here. in which this lesion is arising from this area right here. And this area right here is a sphenopalatine foramen. So this is a sphenopalatine foramen. Here's the pterygopalatine fossa. And here's the pterygomaxillary fissure. And if you look at this, it almost looks like a vuvuzela. So if you follow World Cup football, soccer, it almost looks like a vuvuzela. Now, typically juvenile angiofibromas arise just from the lateral aspect of the nasal cavity, and in large juvenile angiofibromas, they have a spread pattern that goes anteriorly and laterally. So what I want to do is make this distinction. One of these is juvenile angiofibroma, and one of these is rhabdomyosarcoma. Which one's which? Okay, which ones say that this is the juvenile angiofibroma? Perfect, it is. And the reason is because the flavoids. Why it's important to know this is that the same percentage of patients with juvenile angiofibromas and rhabdomyosarcomas present with nasal stuffiness. The same percentage of JAFs and nasopharyngeal and rhabdomyosarcomas present with epistaxis. It's the same percentage. You can't really separate it on those two. As radiologists, we're always taught adolescent male, nosebleed, juvenile angiofibroma. But more importantly, we have to be able to make sure that we evaluate the images, and we can see here that there are multiple flavoids, and in this particular case, there are no flavoids whatsoever. Because if you tell the ENT surgeon this is a rhabdomyosarcoma, they're going to biopsy it. If you tell them this is juvenile angiofibroma, they'll get some type of angiographic study. If you tell them this is rhabdomyosarcoma, they're going to biopsy it, and the child is going to be bleeding in the office. So from a radiological standpoint, they really are reliant on us to provide them the best information. So therefore, we need to be aware of the imaging findings. Two examples again. This, in fact, was squamous cell carcinoma. This was juvenile angiofibroma. Again, notice the location, similar locations, but look at the flavoids. This is a CT scan of squamous cell carcinoma, very, very aggressive, with fragmentation and high destruction of bone. In this case, here's a juvenile angiofibroma, and we see anterior displacement of the posterior wall of the maxillary sinus. This is what's referred to as regressive remodeling. So MR findings, CT findings, these are the typical ones. So just to review so far, squamous cell is most common, lymphoma is nonspecific. If we see perineural spread, we think of minor salivary gland tumors. Frond-like appearance with calcifications, think of inverted papilloma. In a child, think of rhabdomyosarcoma. An adolescent male, think of juvenile angiofibroma. But let me ask the women in the audience a question. What's the upper age limit of an adolescent male? You don't know? Okay, yeah. Yeah, my wife says it's 57, so it's possible. So here's another example of a tumor involving the sinonasal area. Again, this has a relatively typical appearance with some classic findings to it. So anybody want to take a guess at what this is? Esthesioneuroblastoma. So this is the esthesioneuroblastoma that has the typical figure 8 appearance to it. So in the you don't have snow here in Egypt, but in the United States we can also call this a snowman appearance to it. So the reason why this has this appearance to it is that esthesioneuroblastoma arise from the distal fibrils of the olfactory nerve as they traverse the cribriform plate. So esthesioneuroblastoma will arise in the nasal cavity. They can grow inferiorly in the inferior nasal cavity where there's more space, and they can grow superiorly, and once they get into the intracranial vault, there's no space. So the narrowing here really is because there's a constriction in the upper portion of the nasal cavity. So the first thing that we look for is the presence of this figure 8 appearance. The second thing that has been described with esthesioneuroblastoma is this intracranial cyst. Now, personally, I haven't found the presence of intracranial cysts be helpful, but by the same token, if you see this type of appearance with the figure 8 appearance and you see the cyst, these findings are highly correlated with the presence of esthesioneuroblastoma. Now, what I showed before was the typical appearance for an esthesioneuroblastoma. Realize they can also have a standard appearance as well too. So they can also have a non-specific appearance too. So this was just an example of a recurrent esthesioneuroblastoma up in the high nasal cavity. So for esthesioneuroblastomas, what we look for is this figure 8 appearance. Now, this is an interesting case because if you can understand the MR sequence, you can make the diagnosis. So this is a case of a patient that had a non-contrast coronal T1 weighted image, and again, it's non-contrast, and this is a coronal MR, excuse me, a coronal CT. So on the coronal T1 weighted non-contrast images, what's the finding here that can tell you what the diagnosis could be, or in this case is? Good, good. So what do you think it is? Okay, I heard fat. That's perfect. I heard blood. Or fungus. Fungus typically isn't high signal on non-contrast T1, but there's a couple of other things that are high signal on T1. So melanin, right? And so if it's melanin, then what's the diagnosis? That's it, melanoma. Exactly right. So I was just in Brazil about 3 weeks ago, and they presented a classic case of sinonasal melanoma where the residents, it's an interesting thing, the residents come once a month and they present head and neck cases to all the radiologists in Brazil. And it's a wonderful teaching experience. I should talk to you about that. I can tell you how it's set up. It's really fantastic. Yeah, it's great. And so, and this is just an example here of melanin, the high signal non-contrast T1, and that's melanoma. So this is a pathological example of melanoma. This is the dark signal that we see with melanin. These typically arise from neural crest cells. The age is somewhere between 50 and 70 years old. And how do we identify this? Well, we tend to look for blood products and also melanin as well too. Now, one thing about melanoma, it can have some atypical, or I should say a varied appearance to it. In general, when it is involving the bone, melanomas tend to grow slow. So as a result, the bone erosion tends to be a little bit slower. In fact, there's more bone expansion. But because it grows so slow, they can also present at a very, very advanced stage as well, too. So this is another example of melanoma. And this is a fat-suppressed T1 weighted images, again, just to emphasize the presence of melanin, which indicates a diagnosis of melanoma. So in order to look at melanoma, we look for that high T1 signal. Now, here's an example of a patient, this is the original case, of a patient that ended up having a very large intraocular mass, this was done in the 60s, and another mass on the opposite side. And at this time, they didn't really have sophisticated radiation therapy techniques. So this patient was treated with very, very high dose radiation therapy to treat these bilateral retinoblastomas. And then about 20 years later, the patient presented with this mass involving the maxillary sinus. So if you see this type of appearance, what type of disease must we now think about occurring in the maxillary sinus? What's that? I think I hear it. It's in the same plane. So it's not necessarily a chondrosarcoma, but it could be. But the sarcoma is associated with what? This was osteosarcoma, but this was radiation-associated sarcomas. So in this particular case, this demonstrates that, I don't say radiation-induced. I made the mistake of saying radiation-induced one day, and my radiation oncologist got very angry with me. They claim radiation does not cause it, it's associated with it. So I leave it like that. But in general, radiation-associated sarcomas are a rare complication following radiation therapy. Typically, they're seen with high doses, as what we saw before. And histologically, they have to be distinct from the original tumor. And the reason it's felt to cause this is felt to be some specific genetic alterations from the radiation therapy involving P53, retinoblastoma gene, or the MYC gene. Now, both of these are, all of these are cases of radiation-associated sarcoma. This was involving the maxillary sinus. This was involving the right masticator space, and this was a osteosarcoma that was involving the right mandible after radiation therapy. And again, you can see this sort of characteristic sunburst appearance from the sarcoma. So there's no specific type of sarcoma that's associated, that's radiation associated. All of them are. It just depends on how the cells differentiate. Okay, so if you have any incidents of prior radiation therapy, think about radiation-associated osteosarcoma. What about this one? So in this one, we have extraaxial mass. This is arising from the planum sphenoidale, and we can see it's an extraaxial mass with dense enhancement, and occasionally you can see calcification within this. So any guesses what this is? You got it. It's meningioma. Perfect. Exactly right. So meningiomas, I think we all know there's benign, there's slow growing. Involvement in the sinonasal region is rare. Occasionally, this was a meningioma that arose from the maxillary sinus. This was another one that arose from the nasal cavity. This one was involving the planum sphenoidale. And part of the way I'm giving this talk is you've probably heard of every one of these diseased entities, but you may not have put it in a format in which you can understand it. So the whole goal of this is every one of you have heard of meningioma, but when the referring physician sends you a sinonasal study to review, they don't want, it could be X, Y, and Z. They know that they can biopsy it. What they really want to understand is how would you prioritize your differential diagnosis based on the imaging findings. So the way we put meningioma to the top is that we look for these extraaxial masses, we see diffuse enhancement, and we also look for the classic dural tail. So everyone sees the dural tail as we see here. Okay. Now, what about this one? Now, the key thing here is a non-contrast CT. Non-contrast. Ossifying fibroma. So that's good. This was a fibroosseous lesion. So someone earlier mentioned fibrous dysplasia. You said non-ossifying fibroma. There are about 10 different bony lesions that all have some different components of fibroosseous matrix. And the way that I was taught, again, in the last century, is there's a lot of overlap between the radiological appearances of these various fibroosseous lesions. So what I've always been taught, and I still teach my residents and fellows, unless it's absolutely classic, I will just call this a benign fibroosseous lesion, which is what this was. So this is a non-contrast CT. So what we're seeing here is not enhancement. What we're actually seeing here is a matrix within the maxillary sinus. So the various fibroosseous lesions look like this. If you see rings and circles, think about some type of cartilaginous calcifications. And I can tell you, I've never seen a ring or a circle before. The MSK guys, musculoskeletal radiologists, tell me they can see, and I've never seen it. Ground glass appearance, then you can think of the classic fibrous dysplasias. And just realize too that chondromas are indistinguishable from low-grade chondrosarcomas in most cases. So again, if I see something like this, I let the pathologist make the determination. So this is a classical example. If I see this, I'll say it's fibrous dysplasia, end of story. If I see this, I'll call it an osteoma, end of story. But if I see something like this, I don't know what it is. I'll just call this a fibroosseous lesion, and the pathologist tells me it's an ossifying fibroma. And this is just an example of a patient that has Paget's disease. Excuse me, it wasn't fibrous dysplasia, it was Paget's disease. And this was Paget's disease that had sarcomatous degeneration, a very, very unusual case here. Very, very rare. It occurred maybe less than 1% of cases, but very, very rare to see. So here's our outline so far. And the last thing that we'll talk about is this. Oh, I'm sorry about that. So here's an example of fibrous dysplasia involving the turbinate. This was an example of a chondrosarcoma. Again, I can't tell the difference here. And then I saw this lesion here. And there's an important lesson in this lesion here. So I looked at this and I said, I know what this is going to, I give a beautiful differential. I thought this was an enchondroma involving the turbinate. Then I thought if it's enchondroma, it could be a low-grade chondrosarcoma. I thought, well, maybe it's a low-grade osteosarcoma, right? Could be an osteoma involving the, right? All good, right? Anything? Would anybody add anything else? Yes. So it turns out this was an eraser. So years ago, perfect, you were perfect. So years ago, the child had the eraser on a pencil or something, or was it eraser, and he said he lost the eraser. Lost the eraser. That was when this was an adult, and it turns out he presented with this mass, and when the surgeon went in to remove this, and they took it out, and they tended to pathology, there was an eraser. You know an eraser? Yeah, there was an eraser in the middle. So this was an eraseroma. So you did perfect. So that's one thing to always remember in your differential diagnosis, in the back of your mind. If you have an unusual case and the cavity that you're looking at communicates with the outside, you always have to consider the possibility of a foreign body. So I know a lot of you are taking pictures. Here's the picture right here, okay? So in summary, what I've tried to do is, you've heard of every one of these differential diagnoses. What I wanted to do is help you when you go into your practice, instead of giving a laundry list of what 10 things it could be, is to help prioritize what it is to better help. So we talked about squamous cell carcinoma, and we talked about the things you should mention when you see a squamous cell carcinoma. Lymphoma is number 2, it's nonspecific. If you see perineural spread, consider a minor salivary gland tumor. If you see a benign frond-like lesion that has calcifications, think of inverting papilloma. In a child, think of rhabdomyosarcoma. In an adolescent male, and again, I don't know what the upper age limit of an adolescent male is, but if you see this with multiple flow voids, think of juvenile angiofibroma. If you see a figure 8 lesion, esthesioneuroblastoma. High T1 signal, melanoma. Prior radiation therapy, some type of sarcoma. Skull base with a dural tail, meningioma. Ground glass, fibrous dysplasia. And history, always consider a rhinolith. So thank you very much for your attention.